Hey, so the first thing I want to do is this piece, I'm piecing it all together, is on asthma. So we're going to go through and talk about asthma. This we see across the lifespan too. We see it a lot in children. It can resolve as they get older, but we do see people that have chronic or long-term asthma. The one thing about asthma that you need to remember is it is reversible. Unlike COPD, which is irreversible, but we can fix what's going on. But if you have asthma, eventually you can either grow out of it or you'll have it and you'll need to take the medications to control it. There's more play with asthma. I don't have it. I don't have children that have it, but I do have friends and children that have it, and I know that it can be very scary. So the etiology of asthma, usually there are irritants and other things out there that can cause allergens that can cause the onset of asthma, viruses and other infectious agents. We have environmental toxins. We can have exercise-induced asthma. Perfumes. Does anybody ever remember? I don't want to offend anyone, but I knew a little lady and she was the sweetest thing, but the perfume was, that I'm not really sure, back when all you had was the choice of like Avon perfumes, and some of them smell great, but she wore a floral, and I'm just not a big floral person, and it would be so heavy that I thought I was going to have an asthma attack. Genetics, which is interesting. So, if your mom has asthma, you have asthma, you most likely, there's genetics involved in this. Obesity and emotional stress. So the pathophysiology of asthma is a chronic lung disease. It is characterized by reversible, I need to put that in bold, airway obstruction, airway edema and swelling from inflammation, increased airway hypersensitivity to a variety of stimuli. Once again, asthma is intermittent, it's not all the time, and it's reversible. What happens is we can have a trigger and we'll have inflammation, and then we're going to have airway hyperresponsiveness, and then that's going to cause this bronchoconstriction, and that's when we start to get ourselves into trouble. We're going to see dyspnea, wheezing, use of accessory muscles. We're doing everything to try to breathe, and we're going to have prolonged expiration. One thing about it is we need to understand that the precipitating factor is that it can create inflammation in the airways. It can cause a bronchospasm and edema. And just so you know, bronchospasms can actually lead to death if we're not careful. So we need to make sure that if we have a patient with having an acute asthmatic attack, that we definitely start to intervene quickly. So let's move on further so we can find out what we need to do. Once again, as we look at this, the signs, symptoms, and diagnosis, usually it's diagnosed by history and physical exam, but one of the big things I want to point out is pulmonary function testing. That is how we actually diagnose our asthma. We also use pulmonary function testing to diagnose COPD on top of some other things. If we do ABGs, we can also do ABGs. If we get an arterial blood gas, we're going to have a decrease in our PaO2, and we'll have a decrease in our SaO2. So we're going to see oxygenation go down on our ABGs. The signs and symptoms, once again, that difficulty of breathing, wheezing. Sometimes you won't hear anything, and then you can hear a wheeze. It depends on how constricted they are. But we really hope to hear air movement of some form, prolonged expiration, and use of accessory muscles. When people are struggling to breathe, that is not a good sign, no matter who, and especially in children. Also, one of the things that we want to make sure that we do is that we teach our patients that we have some short-acting bronchodilators and long-acting bronchodilators. So they need a short-acting bronchodilator to help with an acute asthmatic attack, and a long-acting to help treat to take daily for long-term control of their asthma. Our short-acting bronchodilator for acute asthma, it's a reliever drug is what we call it. It is albuterol. So your albuterol inhalers are our short-acting and reliever drug. And then our long-acting is salmeterol. And this one is what I said, you take it daily, and that will help hopefully control a long-term control of your asthma. The other thing that you need to teach your patient too when it comes to medications is they should always be carrying an emergency inhaler so that they can get immediate relief if they have a sudden onset and wherever they are. So they should always have one on them. I wanted to share that with you. So talking about asthma, we're going to look more at the child. It's rarely diagnosed in infancy. We look usually if we suspect it with the infants to have respiratory obstruction or dyspnea. It may result from decreased smooth muscle of the infant's airway. Just different things are listed here. Lack of muscle elasticity in the airway. Or if the infant is they're fatigued, an overworked diaphragm and muscle, and it can cause a lot of issues. So we can look at different things, but normally, just so you know, it's not diagnosed with the infant. One of the things that you need to understand that when it manifests, it's an obstruction most severe during expiration. They'll take an inspiration, they're working, but their expiration, they struggle. During acute episodes, patient can cough and wheeze, usually during expiration. So we're seeing more during that expiration when they're breathing out than when they're breathing in, even though they will be trying to struggle, and it will progress if we don't intervene. Signs of air hunger is flaring at the nostrils. We talked about it with COPD. We've talked about it with RSV, some others. When you are air hungry, the nostrils will start to flare. The body is naturally trying to get air in, so it's going to do that. You're going to use your accessory muscles. Orthopnea appears. The other thing is we're looking at that expiration piece with asthma, but we still are really struggling just for air. We're not getting the oxygen. That's why we're seeing that decrease of our PaO2 and our SaO2 on our ABG. So we're starving for oxygen. We're starving for air. Chronic asthma is manifested by discoloration beneath the eyes, allergic shiners. Look at the dark circles. I look like I have it. I don't. I don't know, I need more makeup on this thing. Slight eyelid eczema and mouth breathing. That's what we'll see. I love this slide right here. To me, I'm a very visual person. I like to see a picture. So the normal airway to the left, you see the muscle, you see the little bands and the lining. See how open that is? Now look at the one on my, I guess it would be your left, my right, but the muscle is tightening around, inflammation and swelling are taking place. Look how small. And on top of that, we have excessive mucus in there. So we're causing even more of an airway obstruction so that we can't get air in and out. So we have the normal and the other. But if that's not the most visual thing you can see, how small and tight that gets, then add stuff in, we're really going to be struggling for air, and unlike a normal. So if we don't do what we need to do to help our asthmatic patient in an acute attack, if we don't do it, they can go into status asthmaticus, and that actually is a medical emergency. It's continued severe respiratory distress that's not responding to the drugs that we're using, not even epinephrine or anophyllin. And that is very, very scary. It is a medical emergency. And as the nurse, you are going to be preparing your patient for oxygen, intubation, and ventilation. So we're going to get oxygen, try to oxygenate best as possible as we prepare for the doctor to intubate and then to put the patient on a ventilator. It's an ICU admission, supplemental oxygen, IV medications, frequent vital signs are needed. Pulse ox, we need to have a continual pulse ox in them so we're seeing. What we see on the monitor with status asthmaticus is pulsus paradoxus. That's what you're seeing when you hear that. If you hear that term, pulsus paradoxus, is what we see with status asthmaticus, is we'll have a decreased systolic blood pressure during inspiration. So they'll take a breath in and our systolic blood pressure is going to go down. Now, if they're in the ICU, we can monitor that. We can get bronchodilators, epi, and corticosteroids for status asthmaticus. But the main thing is we've got to get an airway and we've got to oxygenate immediately. And that's why we have to intubate and ventilate. A couple more things before we move on and discuss the various oxygen delivery devices up here. You've already had those in your first semester for my students. If you haven't, it's a review. It's a review for you guys too. I want to say a couple things. A peak flow meter, it is so vitally important. I think there's a video for you on how to use and discuss what is all needed with that. But just so you know, you always need to do it 3 times and you're going to record your highest reading, your highest number. This is keeping tabs on your airway narrowing. So what it's going to do is it's going to help, hopefully it does this, you get a number, you'll know if you're narrowing, you're going to have an asthmatic attack, and you'll be aware of it before the actual symptoms take place, so you can do take your inhaler or whatever and prevent it from progressing into something worse. That's your peak flow meter, and it's very important. I did provide you a link down in just a minute. You'll see it on this PowerPoint. And that is a link to a YouTube channel. She does a great job explaining how to use the peak flow so you can see, and she talks about it. And I think that will be helpful for you. Also, one other thing about asthma that I want to add is that if you have exercise-induced asthma, you want to utilize your bronchodilator 30 minutes prior to exercise. Before you start your exercise. And so if you have a child that has asthma that plays a sport or anything, they need to have that that inhaler, and they need to give themselves their bronchodilator inhale 30 minutes prior to going out there to run on the field to play soccer or do whatever they're doing. They also should always have their emergency inhaler or their coach or someone, so that if something happens that they do have their emergency one also. Now let's move on. So these are oxygen devices. I just put this on because 1, it's in your chapter, and 2, I think it's a great review. So we have the face mask, as you can see. We have a tracheostomy collar, and that's something we're looking at trachs and chest tubes this next week. And so the collar goes over your actual trach. A face tent, so we can have it, and I think you could see those sometimes on the news when we saw footage on the COVID where people would have face tents up. Partial non-rebreathing mask, as you can see, it's a non-rebreather. It has the bag that it's the reservoir. It's going to fill and hold oxygen. It doesn't have to be totally full for you to put on. Just always make sure that your oxygen is coming out. I always I don't touch it because it's going to go in their face, but I kind of run my hand on the top just to feel if the oxygen's will blow and touch my hand. And the Venturi mask, which is a really interesting thing. I still love them. I've seen them in use. If you want to give 40%, 50%, 60%, 80%, whatever, I want to say it goes up to 60, 75. I can't remember. I'll have to look again. But usually what you do is this little device at the bottom that you see there, you twist it and it'll tell you how many liters to put on your flow meter on the wall. So let's say it's 6 to 8 liters, something like that. Then it's going to give you the percentage of oxygen you have it on. It's a Venturi mask, and they're usually color coordinated. It's kind of nice. If we get a chance in the clinical setting, or you do, or you run into a respiratory therapist, some places aren't using those anymore. They're doing some different things. There also, that's not in here, that should be added, is our high flow nasal cannula, because we are using high flow oxygen now and we can give it through a nasal cannula, which is great. So they don't have to have something over their face. It helps. So I decided to put this up. It's chest tubes and closed drainage. You will be looking, my students will be looking at chest tubes this next week. You guys will be. If we have air or blood that's flowing within the pleural cavity, we can have a chest tube. If it's air or blood, it's going to help with re-expansion of the lungs, so it's very important. We always need to assess our respiratory status of the patient. If you ever get a child that comes in that's having difficulty, first thing you want to do is assess their respiratory rate and what's going on. Just remember that. The site at which the tube is inserted into the chest and the length of the tube for kinks. These are things that you want to assess. Never want a kink, because guess what? If you have it in to expand a lung and you've got a kink, the lung's going to collapse still or stay collapsed. So we want to make sure there's no kinks, that it's not detached, and that the system is all intact. It's a closed drainage system. The amount of character of the drainage, is it blood? Is it serous? Is it serous sanguineous? Sanguineous is blood, serous is kind of yellow fluid. We need to know that. If it's air, you're not going to see anything. It's just there if you're looking in different atriums. Those are the actual little systems, and we'll look at that. Okay, this is a great little slide. It's a location of sites for insertion of chest tubes. Site of insertion for a pneumo, you can see the pneumo there where the lungs kind of collapsed. They've come in and put the tube in there. One thing about insertion of chest tubes that you need to understand, they're painful to have. People are very uncomfortable with them, but they're doable. I think they can work with them. But underneath each rib are tons and bundles of nerves. And so if a chest tube is going in, the chest tube needs to kind of slide up over the top of the rib, the top part, instead of the bottom part, to hopefully help prevent that injury of those nerve endings and also any more pain than what they have to have. You can see that they have one, if it's fluid, they can put it in for fluid and it'll drain the fluid down into the tube. It just depends. If they're having open heart surgery, they can have chest tubes. They'll have 2, sometimes 3, depending. They come in down here. They're laying up kind of sandwiched around the heart, if you can see my arrow. And then sometimes they'll have one for the pleural piece. So it just kind of depends on what went on in surgery. The surgeons know, and those are placed, sutured in, and they'll stay in until the drainage is at a certain level that the doctor wants, and then those tubes will come out. Sometimes people have them for a few days. Some people get them out within 24 to 36 hours, depending. This is the disposable water seal drainage system. This is kind of what you'll see in the hospitals if you get a chance. Atrium is a company that actually makes closed systems. I'm sure there's other systems out there. That's the one I seem to see most. There's 2 different kinds. There is a water seal. They all have a water seal. One will have actual water in it, and one is a dry. So it'll say ocean if you have the water, and it'll say oasis if you don't. What we normally see is in the ERs, you'll see the ocean one where it's bubble, bubble, bubble. And then the oasis one, you won't see that bubbling. You'll see that up on the floors and in the ICUs. There's water here. Here's the patient. It's down in here. The drainage will come down. As the drainage fills up, it'll spill. It can spill over, so we can measure it hourly, daily, whatever we're doing. If it continues to fill, it'll spill over, and then it's time to change this actual device. This will go over to suction. There's a little accordion up at the top. It's hard to explain, but when you have the right amount of suction, this little accordion will pop out, and we know that we're getting the proper amount of suction to create this closed drainage system to help drain whatever's coming from the lung, air or blood or fluids, whatever. So the next thing that I want to look at is tracheostomy. And for my students, if you will, please make sure you read the pages that have been assigned. There's stuff, there's boxes, so you can get different information. I'm giving you some, but you need to read your information and add to the notes that you take. So let's look at trachs. Endotracheal intubation and tracheostomy. We're not going to look at intubation today because to me that's an emergency situation, and you will get that next semester for my students in emergency. Endotracheal intubation means we're putting a tube in, but trach is where we want to look at. Tracheostomy is a surgical incision into the trachea, or people would say windpipe, for the purpose of inserting a tube through which the patient can breathe. If we can't go through the nose or down the mouth, we sometimes have to do emergent crikes. We'll go in here and do that. We'll cut open and then go in. But they're down here in the trachea, they can go in. If you've had a tube down, an ET tube, an endotracheal tube for a while, sometimes what we have to do is it's going to break down the mouth and the lip, or if it's in the nose, it can break down the nari. So we need to get it out. They can't have them for long periods of time. It's going to erode the back of the throat if we're not careful. So we get a tracheostomy. And so we send them to surgery. They make a cut down. And it's surgical incision into the trachea for the purpose of inserting a tube. A little tube will go down depending what size person. They have different sizes for everyone. And then it can be connected to oxygen or a ventilator. And then sometimes they'll have a little valve in there so that they can talk or do whatever. And eventually it can be taken out and they can cover the hole if they're a long-termer. And sometimes they can close them back up if they don't need it, but you'll see the scar. So the purpose of the tracheostomy is to assist and control ventilation by mechanical means over a prolonged period of time. So if you can't keep, if you're going to have assistance in a ventilator and be assisted with breathing for a very long period of time, that's when you're not coming off the vent anytime soon, you're going to have to get a trach. We have these conversations with families when the patient's in ICU for a very long period of time on a ventilator. They just can't stay that long. You know, after about a week, we're looking to say we might need to do something, depending. To facilitate suctioning and secretions in the air passages of patients unable to cough. One thing about it, if you have an ET tube down or if you have a trach, you can go down and suction the lungs, and we can do that. It's a sterile procedure down in the lungs, and that is something that we learn as a nursing skill. To prevent aspiration of oral and gastric secretions as in an unconscious or paralyzed patient. So what we do, why we put an airway down, an ET tube or a trach, is especially for a long-term trach for a patient, is if they're paralyzed or unconscious for a long period of time, they can't protect their airway. So when they have all these oral secretions, because they're still going to have them, their mouth is there, everything's happening, that stuff can go down into, they can actually put it down in their airway, because if they're paralyzed or unconscious, they can't protect it. There's a reason why we have to be awake and alert to control our airway. So that's why we can put a trach down and keep and protect them. To bypass a constricted or obstructed upper airway. So sometimes there's cancers, different things. Sometimes people will have trachs. You have to go below so that we can oxygenate or provide airway, because we can't seem to get it up here. I had a patient once that had the whole lower jaw removed due to cancer. And so that was a different ballgame altogether, but they were trached. The patient, this is an audience response question. You can read it. And here's the answers. The patient's spouse asks, what is the purpose of a tracheostomy? Which comments demonstrates nursing knowledge regarding the procedure? Once again, a favorite, select all that apply. Of course, I'm being facetious on that. It facilitates suctioning of respiratory secretions. Yes, it does. Does it prevent recurrence of respiratory arrest? No, it doesn't, but it can maintain airway for us. If it prevents aspiration of oral secretions in an unconscious patient, yes. Anybody paralyzed or unconscious, it will prevent aspiration of those oral secretions. It's going to protect the airway. It bypasses an obstructed upper airway. Yes, it does. It can, if that's the case. And is it a temporary airway for face and neck injuries? No, we didn't pick that. I would have probably said yes to that, but it is not the correct answer. It's not a temporary airway for face and neck injury. It's a permanent airway for face and neck injuries. So there's your word. That's the word that you need to like circle or highlight. So it's not temporary. It's a long term. When you get a trach, it's a long term thing. So when we're looking at nursing management with this, we want to monitor continuously signs of respiratory distress. We need to make sure that they're still breathing, that their airway is patent. These things can come out, they can dislodge sometimes. We have to be very careful. Also, too, when we're dealing with patients that are having respiratory issues that are being ventilated and stuff, they can end up with just major thick secretions that can cause airway obstruction in the lung itself. So we need to be monitoring at all times for signs of respiratory distress. That's why they have a trach, because we're trying to maintain an airway, protect an airway, and oxygenate the patient properly. Immediate post-op care. When they come out, it is a surgical incision. These can be very bloody. And so we want to make sure that we take care of. Also, swelling can take place. So we want to make sure that we are observing and looking at the airway, that it's not closing up, that the tube hasn't dislodged. If we're not bleeding and it's pulling and causing an obstruction that way, we want to watch. Also, it's our post-op patient, right? You haven't had surgery yet for my students, but when you're given anesthesia, it puts you to sleep. It puts everything to sleep, including the lungs and everything else. So we need to make sure that we're ventilating properly and all of that. So we want to make sure. But this is an incision. It can bleed, it can swell shut and all that. And we want to make sure that this is tied down, the collar's tied down, that the trach tube is in and secure, because if that popped out right post-op, we could lose our airway. It's very difficult to get those back in when they're fresh. If they're older and they've had it for years and they have it, it becomes just kind of a eroded circle, and you don't have that issue as much. They can actually walk around if they're walking. You'll see people sometimes do that, where they just have a little hole there and then they use a device to be able to communicate. Psychological support. It's going to cause a scar. It's scary. I mean, there's a whole lot to that. You're going to have psychological support, not only for your patient, but for their loved ones. It's a lot to see when you walk in and there all of a sudden there's this thing and there's blood and there's all these things. The bleeding will stop. This will heal. It'll heal. The wound will heal, and they won't have that. But one thing they will have usually is lots of secretions. And they can, so you want to keep it clean. You want to make sure that everything is there. When they come out of post-op, when they first have it, the first 24 to 48, 72 hours, lots of times we will change the dressing frequently because of the drainage that's coming out, all those secretions. But it's something that we need to explain to them. It's scary. So we always need to provide psychological support with this. It's also an altered body image situation because we've cut here in the throat. Communication and rehabilitation. And one thing that we have to do is we have to be able to talk to our patient, because we're going to wake them up eventually when they have the trach, and talk to them. And they're not going to be able to talk back because they can't. They have to have something special so that it'll vibrate through the vocal cords. So sometimes we need boards so that they can point and communicate or write notes, whatever. And then also the rehabilitation piece that, sometimes they can get those out, close that opening, and heal back, and also rehab if they're not going to have it taken out. It's important. I'm so used to clicking on the slides and it goes, and this is a little different for me. So I'll click the slide and forget I'm supposed to stop the recording. I apologize for that. This is what I was talking about, the atrium chest tube. As you can see, this is a better picture. So it comes out, you have a water, sterile water in the back there. You fill it up to the line. You fill this up to the line. And then it connects to the patient, it connects to suction, and this is where the collection chamber, you can see right now they have, it looks like about, let's see, here's 20, here's 25, probably maybe 27, 28, milliliters of blood. This is called a water seal here. This is what's sealing it, water-filled suction chamber. This is here for this, so that we can create this water seal, and that's how we get the it's negative pressure when our lungs are closed. And if we have a trauma or if we have a spontaneous something that causes air or blood in that pleural area, if we're doing it that way, then that's why we need to have it. It creates that negative pressure again. So that's why it always needs to be upright, never tipped over, and always no cracks. It needs to be sealed. If not, you're going to collapse your patient's lung. And if it's on suction, it needs to remain on suction, because if you take it off suction, it will not help resolve the issue. It can hurt the patient. They're going to go ahead and have a collapsed lung again, or fill up with blood, or whatever we're doing. This is the video. This is a YouTube video. It's great. It's how to use an inhaler with a spacer. It's something that you'll have to do, and I'll be honest with you, I don't use inhalers, and it's something that I always struggled with my patient, because I'm like trying to figure out how to connect it and what I need to tell them and all that. This will go through that for you, so it's a good thing. You can click on it. Hopefully it will link you to the video. If not, highlight and open it up in a new link. This is a chest tube video. This is a great video on YouTube. Once again, highlight it. Hopefully you can click it, it'll connect. If not, highlight it and open in a new link. But this is on chest tubes, and it's going to show you about chest tubes. I think it's a really good one, so go ahead and watch that. It's just going to give you a little more feel of what is being said. I think it's kind of hard to read the book and then hear someone talk about it. I like to see it in action. I'm one of those. I'm a movie person, as you can tell. Here's another. I'm going to give you another to watch. It's how to use a peak flow meter. None of these are super long. So this is a great one, because there will be times, especially if you work in a doctor's office, a pediatric, especially if you're working in a walk-in clinic, if you're in an ER, if you're in a pediatric anything, you're going to have to teach them how to use a peak flow meter. And parents and all of that, what they need to do. So here's a video on that. It explains it a little further too, of what you're seeing in the zones and where they are. It's something great to watch and just absorb and learn. So I hope you enjoy. This is the whole asthma chest tube trach. There's more, so go into your reading, add to it, and I will be posting a test review before next week, but way before the Friday test day. So good luck, and I hope that you enjoy, and I will see you soon.